So we are so fortunate to be joined by a panel of experts who will each share their insights and on these critical issues from their perspectives. Following their presentations, we will have an opportunity for a few questions. So first, allow me to introduce our first speaker. First, we have Vicki Bukta, MS, RN, NEA, BC, who currently serves as the Senior Vice President of Care Improvement for the Arizona Hospital and Healthcare Association. In this role, she is responsible for contributing to the organization's mission, which is making Arizona the healthiest state in the nation. By leading collaboratives to improve patient safety and reduce harm in hospitals, improve the patient and family experience, improve healthcare outcomes, and decrease costs for all Arizonans. She is a highly skilled professional with demonstrated expertise in clinical and systems leadership. Vicki is passionate about harm prevention, including harm from opioids and advanced care planning. Vicki has served in nursing and leadership roles within health systems, including Mayo Clinic, Hawaii Pacific Health, and Banner Health. Vicki, we look forward to hearing your presentation on this topic. Thank you.
Thank you, Patricia. Obviously, we didn't rehearse that part, so I apologize about that. So next slide, please. So I'm going to talk to you a little bit about the nursing, about the nursing workforce. We, as a panel, will hopefully cover a broad variety of topics and professions, but my background is nursing, and that's really where we are focused. And ultimately, I'm going to end up talking a little bit more from the hospital perspective, even though I recognize that, especially when it comes to maternal health and maternal care, a lot of that care happens in the community. But we know that absolutely every single role is important. So I'm going to talk about that small niche. So I'm going to go through my slides as if they're up there, and then you can see the pretty pictures. So I'm on the second slide, which is to say that right now, nurse staffing shortage is a national crisis. And this is a quote that came out from the American Nurses Association in 2021, which of course, at that time we were in the middle of a pandemic, but that wasn't anything new. We've had ups and downs in nursing in terms of shortages for years. Next slide. In fact, it turns out that historically, we've had shortages since about 1935. And what happened prior to that was that most care was given in the home, sometimes by family members or neighbors, or there might have been a trained caregiver in the home. But especially when it comes to maternity care, think about it. Most everybody had a midwife. Most everybody had somebody from their family supporting them during that process. And in the 30s, things really changed. We started building bigger cities. So we had cities like New York and Chicago. People moved away from their rural communities, away from their homes, away from their families. And suddenly, when they became ill, they needed to go somewhere to be cared for. Hence the development of hospitals. Well, when hospitals were built, we suddenly had to staff them. And so at that time, the staffing model was to have schools of nursing have all of their students work in the hospitals under the direction of a registered nurse. So generally one registered nurse, like per floor or per unit or per group of patients. And the students did all the work. So basically the hospitals had free labor. Well, when World War II came along, we had about 70,000 nurses who served in World War II. So they literally left their positions in wherever they were working, and they went to serve. That was about 25% of our nursing workforce. And hospitals suddenly realized that they couldn't necessarily function without all of these nurses. And when they came back from the war, they wanted the nurses back, but didn't want to pay them anything because they were used to having free student care. Or free student labor. And so the nurses said, no, we're not going to work for poor wages and poor working conditions. And that was the beginning of the first nursing shortage. The reaction at that time from the nursing community was to increase the pipeline, you know, like let's get more people into nursing. And then eventually other things were tried, like let's add other people with different licenses, like a practical nurse, other assistive personnel. Let's shorten the education so we can pump out more nurses faster. And this has become cyclical over the decades. Next slide. But what happened with the pandemic is that we had something completely different than what we had any time in history happen. And what happened is that we not only had a shortage before the pandemic, which people ask that question, did we have a shortage before the pandemic? The answer is absolutely yes. We were in one of those lows where we had a pandemic. And so, and part of that was because we didn't have enough people in the pipeline going to nursing school. Some of that was due to not enough faculty, not enough space, not enough slots. And in fact, in 2020, we as a country turned away 80,000 qualified nursing students from nursing schools because we didn't have the resources to educate them. And then during the pandemic, we saw more nurses leaving the profession. People hung in there for the most part for the very beginning, and especially when it was really a crisis. And the longer it went on, the more tired they got, and they just said, you know what, I just can't do this anymore. And so particularly for those positions that were at the bedside in hospitals, they left. Most of the reasons that people cited for doing that was because of stress, the short staffing, the high workload, and there was a lot of incivility. So just like we heard stories in the newspapers about people being rude to people on airplanes and, you know, everywhere else in the communities, the same happened in healthcare. Next slide. So real quickly by the numbers, and I don't want to bore you, but we have over 20% of the nurses in our country are over 65 years old and are expected to retire. That's about 1 million nurses. And about 50% of nurses are over 50 years old. And we have an increased demand in registered nurses because our population is aging. So as we continue aging, we're going to need more people to take care of all of us. So, so that really compounds the problem. And then what we see is that registered nurses who are younger than 35 are leaving the profession at the highest rate. So we decided that we were going to take a look at that. And if you go to the next slide, please, really saw that burnout was part of the problem. Now, burnout isn't anything new. It's something that's been in the literature for years, and certainly nursing has been looking at it for years. But it really came again to the forefront during the pandemic. And when we see burnout, what we see is people who they're physically tired, they're mentally tired, they seem to not care, but really they are suffering from moral distress. They want to provide better care, but they just aren't able to. So they feel like then they're not making a difference. They probably are not making as big of a difference. Quality of care suffers. And if you go to the next slide, you can see that it can actually increase patient mortality when we have caregivers who are burned out. There's something in a term of art that we use in nursing called failure to rescue, and that is when there's a change in patient condition and we don't have the staff members responding appropriately to those people who are experiencing that. And we can have longer lengths of stay, and that backs up hospitals, which just clogs up the system and makes the whole thing worse. And as we can see, the patient lives are dependent on the well-being of the nurses caring for them. So we really need to take care of the nurses. Next slide. So if we look at hospital turnover, and I recognize that, you know, there's lots of fields that people can go into, but if we talk about hospital turnover, if we look at this by tenure or how long people have been employed in their position, as you can see, without even reading the numbers, those people who have been in their positions less than a year are more likely to turn over than anybody else. So all employees is higher. This was from a 2024 publication, higher than even registered nurses. At about 40% of all employees are at risk of leaving within that first year, and 34% of registered nurses leaving within that first year. So next slide, please. So why are new grad nurses leaving within that first year of employment? Well, the transition from student to registered nurse is really a shock. Students are taught one way that they think things are going to, the way they think things are going to be when they get into the position aren't necessarily how it turns out to be. The workplace is very complex. There's a lot of broken systems, and challenges, and there's a lot of stress and anxiety. And there's also a theory by Patricia Benner that a novice nurse does not really reach the proficiency stage for about 3 years. So for those first 3 years are especially hard, but we're at most risk within that first year. Other contributing factors, low job satisfaction, again, that compassion fatigue, people just feel like, I can't give anymore. And then negativity and incivility in the workplace. I'll get to this in a moment as to why this is important for us here in Arizona. Next slide. So we said to ourselves during the pandemic, what can we do? And what we learned from Benjamin Franklin is if by failing to prepare, you're preparing to fail. So we came together as a community, next slide, and said, what should we do to really support all of nursing and patient care in our state? And so we, at the Hospital Association, supported the Arizona Nurses Association in some legislation to address a couple different aspects of things I've been talking about. So you'll remember back to one of my first or second slides when I said, typically, what do we look at when we're in a shortage? We look at pipeline. Okay, are we getting high school students into college? Are we getting college students through college? Do we have enough spots for those people? So we have a number of areas where within House Bill 2691, which was passed in 2022, to address the pipeline. So preceptors for those new graduate nurses and student nurses who are in our facilities to actually get a good experience while they're in the facilities. There's additional money for that. There's money for actual scholarships. That's 1802. Preceptors are 1803. And then preceptors for advanced practice registered nurses, PAs, dentists, and physicians. There's also some funding for that. So we got all of that to address the pipeline. And then next slide. And then we also have pipeline funding for behavioral health, which is extremely important, especially for this group, because we're here to talk about maternal mental health as a big part of this day. And money was awarded to community colleges for faculty and scholarships. And to date, $1.5 million has been awarded to the tune of over 500 scholarships to students for these behavioral health professions. And then in terms of the workplace, so now back to that turnover of the new graduate registered nurses within that first year. House Bill 36 or ARS 36-1804 is a registered nurse transition to practice program. So think about it as a residency program. Our legislature doesn't like us to use the word residency, so we call it a transition to practice program. But basically, what we're doing is working alongside those registered nurses, the new graduate registered nurses, to make sure that they have the support to become a competent nurse more rapidly. It provides that support for a full year. We have $2 million, and I say we, ASHA is administering this grant. It's ultimately funded from the governor's office to access to ASHA. So we are administering this for $2 million a year for each of 3 years. And we have preference to small and rural facilities where they couldn't afford to do these programs otherwise. So this is a national evidence-based program. It's a full year. We are providing curriculum and content. The hospital hires, or facility, I should say, hires the registered nurse, and they provide the preceptor, and then we provide all the rest. Anybody who's a licensed medical facility is eligible to apply. So it could be a skilled nursing facility, long-term acute care, behavioral health. We have quite a few behavioral health facilities participating because they just don't have the funding to be able to do these types of things. Next slide, please. So the goal again is to stop that cycle of turnover within the first year. And we know that the preceptor or frontline manager is what predicts that turnover. So we're very invested in making sure that the preceptor is elevated and has a good experience. It's not, oh, I'm stuck with a new person today, but no, I get to be the clinical person at the bedside who is mentoring this person today. We also have an emergency preparedness and response component to our program, which we think is extremely important. Because we never know, as we heard earlier today, we never know when that next pandemic might come along. Next slide, please. So what else are we doing? We're working hard on creating partnerships. We really don't want to work in silos. That's probably the worst thing we can do. We've held workforce summits across the state in both 2023 and earlier this year. We have leaders from throughout the state who are coming together, sharing workforce and data. And the Center for the Future of Arizona has taken up kind of the charge and is leading a healthcare workforce action network. And we really, really need to use data to tell the story. So we're starting to work together as a community on figuring out if we can't have a workforce data center so that when somebody says, do we really have a nursing shortage, or is it just a misallocation because people don't want to work in hospitals, which is what I hear all the time. And if we don't have good data, it's really hard to plan. So we're coming together, the organizations you can see on the slide there, to really make sure that we've addressed that issue. Next slide. I think that's the last one. So with that, I think I take any questions at the end, right? Yes. Okay. Thank you.
Thank you, Vicki. That was really a wonderful presentation. I really appreciate when we always hear percentages, but I think you talking about that million individuals that are going to be potentially moving on, that's really significant. So we'll be taking questions at the end of the three presentations. Our next presenter or speaker is Amanda Scheinson. Amanda is an accomplished professional with more than a decade of experience in government relations and works with the Arizona Medical Association as Director of Government Affairs. Amanda is responsible for leading ARMA's advocacy team in representing the interest of its physician members. Utilizing members' input, she steers the organization's advocacy efforts at the local, state, and federal levels of the government. Prior to joining ARMA, Amanda worked in private sector government relations, where she lobbied state and local governments on behalf of clients on a diverse array of issue areas. Amanda also served as the Director of Legislative Affairs for the Arizona Attorney General's Office and on staff at the Arizona State Senate. Amanda holds a master's in public administration from Arizona State University, yay, and a bachelor's degree in political science with a minor in sociology from the University of Arizona. Amanda, could you tell us a little more about the work that the Arizona Medical Association, your role and work in ensuring healthcare workforce adequacy for mothers and children?
Thank you so much. I'm going to stay sitting because my shoes are pinching my feet. ARMA, just really quickly, we are the largest physician-led organization in the state. We are older than the state of Arizona. We've got about 4,000 members, MDs, DOs, every different specialty, med students to retired physicians. So we're really kind of herding cats when we try to speak with one voice and hit on the big issues that are impacting the ability to practice medicine and deliver care to your patients. We do a bunch of really interesting things. We can talk more about that at some other time if you want to grab me. But one of the biggest things that we have been focusing on as an organization is workforce. Not only is this critical for delivering care, especially in these critical fields of maternal and child welfare, but this is something, this workforce shortage is really, really leading to burnout and frustration. Physicians simply don't have the time to spend with their patients that they want to. And this isn't a scenario that's good for anybody. Patients obviously pay the ultimate price, but doctors are on this 15 minutes with a patient schedule, and this is not what they went to medical school for. This isn't what they dreamed of when they thought, when they decided they want to become a physician. Next slide. I think one of the biggest contributing factors to our physician shortage is the lack of funding for graduate medical education / GME, or more commonly known as a residency. Arizona is far, far behind in our funding for GME positions, and this is due to the fact that GME is largely funded through the federal government. And unfortunately, in 1997, the federal government put a cap on funding for GME. So what this practically means is states that had larger populations in the 90s are getting a disproportionate share of the funding, while high growth Sunbelt states like Arizona are stuck in those 90s numbers. I mean, think about the way Arizona looked in the 90s. It's unrecognizable. So we're dealing with 90s financing and 2024 numbers, and it's just not aligning. So we found a couple of ways to kind of patch this leak and do the best that we can federally, at a state level. But if there's one thing you take away, it is that the federal government needs to take action. These numbers need to be looked at, and something needs to change here. It's just difficult because these states that are benefiting from these outdated formulas do not want that to happen. I would say we should not look at this as a competitive game. We're not going to take away anything from, like New York or California or any of these other states, but we need to add to balance it out for the Sun Belt and these high growth states. Arizona, as I mentioned, is one of the most populous states, and we are 37th for GME. So another important thing to take away from this is GME is critical for ensuring that we have physicians here practicing in Arizona. There's a lot of data to show that when somebody does their training here, they put down roots and they end up staying and practicing in these communities that they're doing their training in. So as I mentioned up here, between 50 and 75% of folks are going to stay and put roots down where they do their residency training. It is incredibly expensive. Obviously, training physicians is not cheap. Not only do you have this kind of overhead, but you have all of the support that goes behind it. It's not something that you can just throw a small amount of money at and you're immediately going to see a solution. It's something that you're going to put an enormous amount of money at, and you're going to see payoff in like 5 to 10 years just to the nature of residencies. Next slide. We have been working really hard at the legislature because obviously this is the world that I live in and this is what I can do. I cannot convince the Congress to take any action any more than anybody else can. So we've done a couple of things that although I'm very proud of what we've done and what we have planned for the future, I'd say they're kind of Band-Aids, and then what we need is a comprehensive look to the future. I'm going to kind of go backwards. Some of the things that we've done previously, it was already mentioned. Healthcare workforce funding in 2022 included $15 million for nursing education and the preceptorship grant program. We're very, very proud of that. We had an expansion of CHIP to 250% of the federal poverty level, unrelated to workforce, but I think really, really important for child health. And then other things we've done include 1 year of access coverage for mothers postpartum. People would end up getting kicked off of access within the first couple of weeks of having a baby, and we know there's a lot that goes on in that first year. We got a raise for OBGYNs in 2022 on access. About 40% of our births in the state, maybe even 50%, are access patients. So if that global obstetrics package is not well-funded and competitive with other states, we're going to lose OBGYNs to places where they can go and make money. Money isn't going to solve all of our problems, but if you're going to notice a common theme in what I have to say, money is going to solve a lot of these. So where this comes really important is especially in these rural and underserved communities. I don't have really current data, but as of a couple of years ago, I think we had 8 counties in Arizona that don't have a single OBGYN practicing. So I mean, you can imagine what this means for moms to be in these counties. They're really left in a situation of having to drive hours and hours and hours to get the care that they need. So looking ahead, what have we done? This year, we introduced legislation that would have created a dedicated funding source for workforce projects in this state. What we wanted to do was take a portion of the premium tax, which is a tax that the insurance industry is currently paying, and dedicate that to workforce projects to be determined by a council of actual healthcare people, including physicians, hospitals, nurses, education systems. So kind of an opportunity for us to create a system that really works for us and benefits us, rather than having to come to the legislature every few years and get, $3-5 million for residencies here and there. We thought this was a brilliant idea. The legislature unfortunately didn't agree with us. Part of that is likely due to the fact that we had a $1.4 billion deficit at the legislature this year. So nobody was really getting any money for any projects this year. But there are probably some other issues too that, if I'm being honest, are going to be a problem, namely the fact that the legislature loves control and they're not really excited to cede it over to people that actually should be making these decisions. Being a little snarky here, but it's the end of the day. So I obviously feel very, very strongly about this proposal. Kind of TBD if we're going to push this particular form through again in 2025. I'm also interested in potentially sending this to the ballot, to the voters. I may not be able to get around the fact that the legislature loves control, and this may be something that we have to have the people of Arizona vote on and get this in the state constitution so the legislature can't mess with it. I do think that in the meantime, while we kind of decide the route to success on that, there's going to be other things that we can look forward to in 2025. I know there's going to be a GME package introduced. And that's probably something that we're all going to be happy to get behind. I think, like I said, a giant funding package won't solve all of our problems, but it'll go a long way, especially if it's something that's done thoughtfully with time for the hospitals to really grow these programs and implement them properly. And then we'd love to also see something that focuses on the needed specialties like family med, OB, and pediatrics. Obviously, we have a physician shortage across the board. But there are certain key specialties that are a little bit more in need than others. And then also focusing on rural and underserved communities. Next slide. I already kind of talked about this a little bit, but we are continuing to find ways to address the physician shortage. We need to address burnout and frustrations. Vicki really talked about this and hit the nail on the head. The practice of medicine has changed. Everything from the hospital setting to private practice, with the burdens that physicians are facing from insurance companies. It's almost impossible to even keep a private practice open these days. Other things we're watching carefully, the consolidation of healthcare, completely a topic in of itself where they have a conference on its own, but I think that's something that's not benefiting patients and is really damaging physicians. So there's a lot to look at in this field, and I think we reached a critical point where the community understands the problem, and so do legislators. I'll kind of end with a quick story from that I won't share her name, but a legislator shared with me that she had been in a car accident last year and was taken to the ER in an ambulance and ended up sitting in a hospital waiting room in a neck brace on a gurney for almost 10 hours before she could get seen by a physician. And she was like, look, I get this. Like I faced it and feeling it, across the board, we need to be taking this more seriously. So it's a hefty problem, but I'm really excited about the direction that we're going in the future and all the brilliant minds that are working on this. Happy to answer any questions when this is over, or please reach out to me anytime.
Wow, thank you so much, Amanda. That was a lot in just a few minutes, but I think your passion to help address this issue of physician shortages in particular is very evident, and I'm glad to know that you are at the helm. So we have one more presenter or speaker that's going to be joining us virtually. And this person is Yara Castro. There she is, Bachelor's of Science. Yara is the Director of Rural Health Strategies with Mariposa Community Health Center in Santa Cruz County, Arizona. She oversees a variety of initiatives focused on maternal and child health, domestic and sexual violence, substance use disorder, and housing. With over 20 years' experience in public health and social services, Yara is deeply committed to her work and leads a dedicated team of community health workers. Yara plays a leading role in county-wide and cross-county networks and consortiums that address maternal and child health and substance use disorder, working to develop sustainable, customized solutions for the community. In recognition of her contributions, she has received the Emerging Leader in Rural Women's Health Award from the Arizona Rural Women's Health Network in 2019. Most recently, she was honored with the 2024 Congressman Raul Grijalva Southern Arizona Community Activist Award. Thank you for joining us today, Yara. It's really great that you're able to do that remotely. So I'm going to kick off the Yara's comments with a quick question for her, and that is, living in the rural part of Arizona, could you give us a little background on the challenges your community has faced around healthcare workforce shortages for maternity care?
Well, first of all, I'd like to apologize. I'm a little under the weather and I might sound a little bit off, but thank you for the opportunity to be here. First of all, I'd like to paint a picture of Santa Cruz County. So we're the southern county in the state, on the border with Nogales, Sonora, Mexico. And our healthcare, we have very limited options for healthcare. In the last 2 years, two private OBGYN practices closed. And also there's only one internal medical provider, and there's also one private pediatric provider. Aside from that, it really is Mariposa Community Health Center, which we are a federally qualified health center, who is has undertaken the health of the community in that sense. We've been around for over 40 years, and in those 40 years, we've expanded to try to meet as many needs of the community as possible by offering an array of services, but also through collaborations and connections with not only community partners, but also statewide and national partners as well. Excuse me. Our population's a little under 50,000 people, and our clinic serves a little bit over half of that population. We have from pediatricians, adult medical providers, family practice, throughout 6 clinical sites. We do have a department dedicated to OBGYN services, which consists of 2 nurse practitioners and 2 medical doctors. We have 2 pharmacy sites across the county, as well as a delivery pharmacy program. Our community health services department follows the community health worker model, and we also provide an array of community health services, case management services through that model. We have 2 specialty behavioral health services, behavioral health sites, and we also have an integrated behavioral health model under primary care, which can also focuses on integrated care for special populations. So just wanted to paint a picture, because obviously during COVID, we weren't the only ones that probably had some challenges, but after COVID, we continue to feel those challenges. Around 2021, 2022, we lost 3 out of our 4 OB providers. They resigned for a variety of reasons, and they left, right? Just like it probably happened in other places. Just this year, we were able to kind of have a full OB department in full force, with the new 2 nurse practitioners and the 2 OB providers, the other 2 OB providers. I'm sorry. There's, like I said, a variety of reasons on why that could have happened. But we also know that it's challenging in rural communities to keep OB or pediatric providers, because they're basically being asked to stay on call for 24 hours, right? So they're supposed to do their regular outpatient coverage, but at the same time, do the rotating schedule for hospital coverage. And that's kind of been the model of how we've done it in Santa Cruz County. And I know that other rural areas across the state do as well. Our local hospital, we see about 500 births a year in our critical access hospital. And we know that the model in bigger cities is to see laborists as hospitals, or we're seeing more laborists at hospitals. And then you have your outpatient providers that provide the prenatal care and other OB services through their clinics, which can be very costly for rural healthcare organizations, not just for us, but for hospitals as well. So our leadership are in talking to our chief medical officer and our associate medical director, they see that a lot of the challenges in being able to recruit and retain providers in our community is that. Aside, younger generations, for example, are looking to more of a lifestyle balance that rural communities, a lot of times we don't offer those options. So it's not just appealing. There's different reasons why our rural communities aren't appealing, right? And also the lack of specialist support can also be a barrier to have to be more insightful for providers to come and work in rural communities. And it's similar challenges that we face with pediatricians at the clinic as well. There's also challenges in recruiting and retaining registered nurses and medical assistants who specialize in OB or pediatric care. We do have a decent workforce for medical assistants, and it's usually the local younger workforce who wishes to stay in the community for different reasons. But then they lack kind of some of that specialty and training and experience that they only gain throughout time. But since the need is growing, we're lacking those specialties as well. I'm sorry. Some exciting news, basically fresh off the press, is that we were recently awarded a 3-year planning grant in collaboration with AHEC to start a family residency program. So that's huge. It's barely in the starting phases. But of course, we'll see the benefits in that, which statistics show that providers end up staying. Can't remember the percentage, but providers end up staying where they might go to do their residency. And there'll also be an emphasis in family medicine providers, since after a 1-year OB fellowship, they can also perform OB services such as C-sections and services like that. So those are just some few of the challenges and kind of where we sit at in Santa Cruz County.
Thank you so much, Yara. It's good to hear all the great work that's going on in the Nogales area. I was wondering if you could talk a little bit about the most recent Our Moms grant that I know Mariposa was able to successfully receive, one of only 2 of the rural maternity and obstetrics management strategies, or more commonly called Our Moms. Can you tell us, this is an award from the Health Resources and Services Administration, more commonly known as HRSA. Could you show or share how the Our Moms grant is helping Mariposa Community Health Center address some of the maternal health disparities in your community, and what specific initiatives you've been able to implement so far? That might be kind of a future question, but if you could just tell us a little bit about Our Moms and then your experience there at Mariposa.
Yeah, so Our Moms, the official start date was September 30th, so a couple of weeks ago. So we're still in the process of kicking off and onboarding and taking all of those initial steps to get the program formally off the ground. However, our 3 overarching goals, so we have, our goals are to formalize a network of rural communities in Arizona to address maternal and obstetric continuum of care, develop models of care and approaches to higher risk families in Arizona, and of course, develop financial sustainability for maternal and obstetric care across the state. So Our Moms, the focus and how we plan to do this is to develop a network, and the formal network and who partnered with us in the grant consists of Canyonlands Health Center, and also through that, we're partnering with our critical access hospitals that both us as Mariposa and Canyonlands works closely with. That includes Carondelet Holy Cross, Mount Graham Regional Medical Center in Graham County, and Cobra Valley Regional in Gila County as well. We're also looking at including Page as we initiate and start off the efforts and kick off the efforts. But through this network approach, we really want to develop a continuum of maternal and obstetrics care from preconception all the way to postpartum services. So of course, including prenatal, pregnancy, delivery, and really trying to come up with interventions in ways that we have a safety net for our preconception, prenatal, and postpartum families. We want to improve delivery environments, including access to specialty care. And like I said, a really strong focus and emphasis on financing sustainable models for care. Some of the initial steps that we're going to be taking, the first year is basically for planning. We're going to be doing a needs assessment throughout these communities, the communities that Canyonland serve and that Mariposa serves, and as well as coming up with a data collection plan. I think the biggest pieces of this is the evaluation component that will come with this project that will really let us be able to measure any interventions we come up with. So with some of the initiatives that we took, even as we started the conversation of applying for RMOMs, since then, especially after the OB crisis we faced after COVID, our leadership over at Mariposa went all in trying to find a solution. And we were able to contract with Southern Arizona Laborist, who is also a formal partner on the RMOMs initiative and grant, and trying to kind of imitate the big city model of the laborist provider at the hospital and keeping our providers, outpatient providers at the clinic. And they're currently providing the 24/7 support that the hospital needs. Currently, I believe we're the only rural hospital with this model. At the same time, our CEO has been strongly advocating at the state and federal level for support from Medicaid and exploring different options for financially stable models, right? Some of the things we've thrown out there, nothing formal, is block funding, increased reimbursement rate. So I was really happy to see a lot of the policy work that ARMA is doing, as well as from last year. So hopefully we can continue that conversation. At the same time, we've started other initiatives within the health center that kind of connect the dots back to our moms and that whole providing continuum of care for this population. Some initiatives that we're working on is we're looking to establish prenatal care, implementing the prenatal care centering model. That'll be different for our community, and exploring a group model of care and hopefully being more supportive for our patients. We've also expanded our prenatal care package for self-pay. We learned from some of the private providers that closed that was very popular and very needed among our population, given where we're located. Also, HRSA is requiring us to implement the one key question of, do you plan to get pregnant within the next year? And we're asking that question to everybody 18 years and older at this time. We plan to incorporate it at the pediatric level, depending on certain age, and also for men. But what that's going to allow us to do is to hopefully better plan and connect individuals who are planning on getting pregnant, if they're not already. Of course, making sure that they're getting pregnancy tested, if that is in where they're at, and engaging them in care as early as possible. But it also gives us a time, or gives the provider a time, to do some medication review and review their chronic conditions to see if there'll be any challenges throughout their pregnancy. And of course, connect them to the appropriate referrals. And some of the resources that we have internally that those referrals, that they can benefit from those referrals, not only from the community, but internally, is we have our Health Start program. We've had it for over 30 years, and it's following the CHW model. And it's a home visiting program for pregnant and postpartum women. And we offer education support, and of course, always supporting our families to increase access to care for pregnant and postpartum women. We also offer medication-assisted treatment services that we can serve pregnant or postpartum women, and make those connections for additional support and referral or peer support, whatever is needed. We also have WIC in-house under the Mariposa umbrella, so that is also something that we're able to coordinate internally. We're also implementing the Edinburgh postpartum depression screening to all postpartum clients, not just at their postpartum visit, but for 12 months following that. That is something new that we're doing. We know that sometimes patients don't come back to either their postpartum visit or continue care within that year. So we're also including it at the pediatric routine visits for the baby's first 12 months of life. So hopefully there's those different intervals where mothers can take we could do the depression screening with them and make appropriate referrals and follow-up care as needed. Our specialty behavioral health department is starting a postpartum support group as well. One of our therapists recently got her certification in perinatal mental health through Postpartum Support International, which is again something that will be hopefully supported, providing additional support through our community health workers as well. So these are just some initiatives that are underway. I'm sure that with our moms, as we continue the efforts through the needs assessment and coming up with collaborative interventions with our partners, we're able to really see and dive deeper into the needs of our community, if these interventions are working, or what else do we need to come up with to really address the need of our community and our pregnant moms. To make sure to increase access to prenatal care, of course, and hopefully increase access to safe and healthy labor and delivery services locally. And like I said before, by adding the evaluation component with the support of our moms, that will really help us measure this and kind of see where we fall. And hopefully we have replicable interventions for other rural areas, not just maybe for Arizona, but for other similar areas across the country.
All right. Thank you so much, Yara. That was very informative, and it sounds like you guys are really busy, but doing some amazing work in the Nogales and Santa Cruz County area. I wanted to just see if anyone in our audience has any questions for our guest speakers. We do have just a few minutes, actually, maybe a question or two. Okay, we have one back here. Yep.
Thanks. With concerns surrounding when we talk about physician burnout, nursing burnout, and leaving the workforce, both in the hospital and in the community, with the consolidation of healthcare and the increase in expectation of physician oversight, direct physician oversight to unlicensed personnel, how are we as healthcare advocates ensuring that traditional non-hospital nursing roles and those within the hospital who are currently experiencing scope creep and being priced out due to business and non-medical models being preserved in the workforce?
Who would like to take that question?
Boy, that's a huge.
Sorry.
Can you just summarize the question in your own words? Yeah.
Curious with our push to uphold, because we're having this disintegrating healthcare system, that we're seeing the leave of nurses, of physicians, of nurses being burnt out, of physicians being burnt out and taking second careers even. But we're seeing a big push for unlicensed personnel, but we're also being told at that point that those unlicensed personnel are going to be under physicians, and physicians are going to be in charge of these unlicensed personnel. How are we upholding the scope creep that might be happening within licensing?
Touch on that a little bit. I think obviously my take on behalf of physicians is that everybody deserves the highest standard of care, and the answer to shortages is not to put folks with less training into medically underserved areas. So that is, kind of my first and foremost answer. But I do think that there is like a role for all members of the healthcare team working together under physician leadership. There shouldn't be anybody unlicensed providing care like that. That feels terrifying to me. But there's a really important role for all members of the healthcare team to work together and play the part that they're trained to do, which, from my perspective, obviously is with a physician at the helm.
I would add one thing, and that is we do want people to work to the top of their license. So for those people who do hold a license, we do want them to be able to facilitate to work to their full scope of practice. So for example, a nurse midwife or a nurse practitioner. We do want them to be able to practice their full scope.
And unfortunately, we are out of time, but really want to thank our presenters, our speakers today, very vast and diverse perspectives, but obviously with the same goal in mind, and that is to continue to assure that we're all receiving safe and appropriate care where we need it and within the community that we choose to live in. So thank you so much.